Yeah. Case
Okay.
scenario?
Okay. Sorry for the delay. Now I'll just start. So I begin with the case scenario. Like this is a 53-year-old male underwent a major surgery, pancreatic duodenectomy for chronic pancreatitis, and 1 month after the surgery, he comes back with severe malnutrition caused by some digestive disorders. Now, once the patient gets hospitalized, the patient was put on TPN because he was severely malnourished, and then the treatment of water electrolytes imbalance was started. After 3 days of TPN, hello, yeah, hello, am I audible now?
Yes, sir.
Acha, okay. So
Hello?
after 3 days of
Yes, sir.
I'm
Yes, sir. Yes,
okay.
sir.
After 3 days of TPN, a severe hypophosphatemia occurred. The serum levels were less than 0.25 millimoles per liter, along with hypokalemia and hypomagnesemia. Now, this is a classical case of refeeding syndrome, and we have to be cautious whenever we start the nutrition again in a patient who has not been taking proper nutrition for days or weeks. Coming to just a
Fully
brief
exactly.
idea about a historical background. So the first concept of refeeding
Yeah.
syndrome, it started after the World War when the prisoners were liberated from the prison and they were started the
That I
feeding again after a period of starvation. It also was like the clinicians also learned about the syndrome from some famines like the Leningrad or the Netherlands famines. Patients with marasmus and kwashiorkor who were nutritionally deprived for days and weeks, and as far as the incidence is concerned, it is a very high incidence, especially in critically lyso patients. It can range anywhere from 34 to 52%. Now, what constitutes refeeding syndrome? Now, it involves, if you go, there is no classical definition of refeeding syndrome. It's a very, as the name suggests, it's a syndrome. So, there will be a constellation of signs and symptoms. And even the definition is not exactly clear, but it involves a lot of electrolytes and metabolic abnormalities associated with it. So, refeeding syndrome involves metabolic abnormalities when a malnourished person begins feeding after a period of starvation or poor intake for days or weeks. It is defined as severe electrolyte and fluid shifts which are associated with metabolic abnormalities. Now, the hallmark feature of refeeding syndrome is hypophosphatemia. Though it is not just restricted to phosphates, but it can also involve sodium, it can involve thiamine deficiency. The patients can present with hypokalemia and hypomagnesemia. Now, I'll be talking something about hypophosphatemia. The reason being, this is the classical feature of refeeding syndrome, and most of the times the clinicians are not aware of hypophosphatemia in clinical settings. So, phosphatemia, now if you look at hypophosphatemia, there is a way of classifying it, and that is based on if you measure the serum levels of phosphate, it can be mild, moderate, or severe. If it is ranging somewhere from 2 to 2.5, it is mild, 1 to 2 is moderate, and anything less than 1 milligram per deciliter is classified as severe hypophosphatemia. Now, if you look into the epidemiology, why do we talk about hypophosphatemia? It is equally prevalent in surgical and medical patients. Now, if you look at the values of hypophosphatemia, the classification, there is no classical value. Like people have started taking hypophosphatemia less than zero point 0.8, somebody has taken as zero point 0.5, somebody has taken as low as zero point 0.2. But the crux is that yes, hypophosphatemia is common. It is common in both surgical and medical patients, and the incidence can range anywhere from as low as 2.4% to as high as 100%. And if you look into particular group of patients like patients with sepsis, the prevalence is almost 80%. And patients with head trauma, it can go as high as 80%. And patients with heart failure, sometimes it touches even more than 10%. So almost all patients who are critically ill who need hospitalization or get hospitalized, they are predisposed to hypophosphatemia. Now, why we are just worried about hypophosphatemia? The worrying point is that it can sometimes be an independent predictor of mortality. Now, there are several studies which have tried to correlate hypophosphatemia with mortality as an outcome measure. And they have found that in hospitalized patients more than 65 years, the odds ratio for death is 2.79 if they have hypophosphatemia. It can go as high as 18.2% as compared to those patients who have normal phosphates during their hospitalization. In surgical critical care, if you look at the incidence of hospital mortality, it is somewhere 30%. That is almost double the patients compared to the patients who have normal phosphates. In septic patients, the odds ratio for in-hospital mortality touches nearly 8. So that means they have got 8 times higher chance of mortality if they have hypophosphatemia, either during admission or during their hospitalization. So it is an important electrolyte which should be considered in all patients who are suffering from malnutrition or who have got some risk factors for malnutrition. Now, what are the risk factors? If you look into the risk factors from the guidelines which have been updated and they keep on getting updated on a regular basis, there are a number of risk factors. It starts like from fasting, anything more than 5 days. Some guidelines say 10 days based on the body mass index, low body mass index, patients who are already malnourished because of some predisposing illness like kwashiorkor, marasmus, chronic malnutrition because of carcinoma or in the elderly, chronic alcoholism. So there are a number of reasons. The list is like the important to understand this list is that you should know that what are the risk factors. So the moment you realize that this is my patient who's at risk of developing a refeeding syndrome and hypophosphatemia, you start becoming aware for the monitoring of electrolytes in this vulnerable group. Now, if you look into the patient risk factors, and then there are some physiological risk factors or risk factors which are associated, some interventions which are done for the patients who get hospitalized. Now, it can be because of decreased intestinal absorption, which can be because of malnutrition. Patients are on phosphate binders. Their patients are suffering from diarrhea, vomiting. The patients have got high gastric residual volume, so they are on constant nasogastric suctioning. There can be a redistribution of electrolytes, including phosphate, because of alkalosis, diabetic ketoacidosis, insulin therapy, because of the vasopressors which are going on. And at the same time, some patients may have increased renal excretion of electrolytes and including phosphate, which may be because of metabolic acidosis, use of diuretics, steroids. So these are some of the reasons which should be kept into mind that if my patient is on such therapy or if undergoing these interventions, then this patient is also likely to suffer from dyselectrolytemia along with hypophosphatemia. So, what is the sequence of refeeding syndrome? There is a patient with malnutrition or starvation, which may be existing for days or weeks. You start the nutritional replacement, and the patient suffers refeeding syndrome. Now, this is the pathophysiology of refeeding syndrome. Now, once you start the nutrition, especially the glucose aspect of nutrition, immediately there is increase in insulin secretion. Now, insulin we all know is an anabolic hormone, so there is an increase in the glycogen and protein synthesis, increase uptake of glucose, phosphate, potassium, magnesium, and water. And we all know that whatever cycles are involved, like the Krebs cycle, the citric acid cycle, thiamine is a cofactor for all these processes which are involved in the increased protein synthesis and glycogen synthesis. So there can be increased utilization of thiamine. Now, at the moment there is increased uptake of these electrolytes along with thiamine, the patient can immediately manifest with hypophosphatemia, hypomagnesemia, hypokalemia. The shift of water along with these electrolytes, so there can be water retention, and at the same time, a very important aspect of refeeding syndrome is thiamine deficiency. Now, how do we monitor the phosphate levels? Now, if you go into the literature, what is the evidence? And this is one of the largest studies which has come regarding the monitoring of phosphate levels from Netherlands. It was conducted in 79 hospitals, especially the ICU settings. And what they found was that the percentage of monitoring of phosphate was almost 40% on admission. Daily was almost like ranging from 40 to 50%. Some ICUs were monitoring 3 times a week, 2 times a week, once on a weekly basis. Only when there was some indication, clinical indication, or the clinicians were suspecting hypophosphatemia, only then the monitoring was done. Some patients were on renal replacement therapy and patients on TPN. So now, even if the patient is on renal replacement therapy and the patients who are on TPN, the recommendations are that the phosphate should be done on a daily basis. But still, if you look at the percentage of monitoring in this study, it ranges somewhere from 60 to 80%. So still, the awareness as far as the clinicians are concerned regarding the management and the monitoring of phosphate is still not 100%. Now, why we are worried about this dyselectrolytemia, which occurs as a part of the refeeding syndrome? Because they have systemic manifestations. So there are a lot of systemic manifestations associated with phosphate. They can include almost any system like cardiovascular, renal, skeletal, CNS, endocrine, hematology. And similarly, we all know about the potassium, hypokalemia, what all it can cause, the systemic disturbances. Then there can be magnesium deficiency. The symptoms and signs involved with hypomagnesemia. Similarly, the sodium, and at the same time, the deficiency of thiamine can manifest with congestive cardiac failure, severe lactic acidosis, and severe muscle weakness. We all know that thiamine is a part of enzymes, cofactors, and so deficiency it gets marked, especially in patients with malnutrition who are started with nutrition, any kind of nutrition, it is whether it is enteral, parenteral, or a combination of this. So we should know the clinical manifestations, and at the same time, we should have a high index of suspicion in the select group of patients that these are my patients who have got some risk factors for malnutrition, and they have got some risk factors for developing dyselectrolytemia once I initiate my nutrition. And the frequency of monitoring of this electrolyte should go up. So, what should be the treatment strategy to avoid this syndrome? Regular monitoring of electrolytes, regular supplementation of phosphates, magnesium, and potassium. Glucose monitoring, we should avoid dysglycemia, either hypoglycemia or hyperglycemia. If there is hyperglycemia, we should have a tight glycemic control. Try to keep the sugars less than 180. If needed, we can put the patient on insulin infusion. Fluid balance is extremely important. Neither the patient should be underfilled or the patient should be in fluid overload. And at the same time, as I told you, besides electrolytes, keep a watch on the thiamine. Even if you're not monitoring the thiamine levels, just give thiamine supplementation to all such patients who are at risk of developing this refeeding syndrome. The dose recommended for thiamine is 300 milligrams initially. You can give it for 3 days, and then you can follow it with 100 to 200 milligrams for at least 7 to 10 days. Now, as far as the caloric buildup is concerned in these patients who are malnourished due to any reason, the caloric intake cannot be reached to the maximum what the patient needs in a day or two. So you have to gradually build up on the caloric intake. So you have to begin with maybe one fourth, then go up to half, and then 75%. And you may take 5 to 7 days to reach the exact caloric intake and the protein requirements or whatever nutrition you want to supplement to a particular patient. So it has to be a gradual advanced feeding for such patients, especially those patients whom you identify as malnourished patients. Now, what are the recommendations for phosphate replacement? Now, there can be two types of recommendation. Whether is the oral and the other is the intravenous. Now, if you encounter mild deficiency of hypophosphate of phosphates, then you can go for oral replenishment. Otherwise, the recommendations are that any patient who has got moderate to severe hypophosphatemia, the replenishment has to be by intravenous route. Now, these are some guidelines which are present in different textbooks. You can get from ICU textbook, you can get from evidence, and a lot of guidelines are available on the net. But like whenever you encounter moderate to severe hypophosphatemia, it has to be intravenous. It can never be oral. And then the supplementation has to be over a period of 4 to 6 hours. And during supplementation, your frequency of monitoring has to go up. And some patients you might even need to monitor the electrolytes on a 12-hourly basis. What phosphate replenishment do we have with our settings? Now, this is like if you can have want to give intravenous phosphate at SGPGI, we have got pot phos. 1 ml gives 3 millimoles of phosphate and 4.4 millicoulomns of potassium. And if you want to give oral phosphates, we have got AdPhos sachets, and one sachet gives 6 millimoles of phosphate, which has got 20 millimoles of sodium. At the same time, I'm telling you, like I'm focusing on phosphate because this is one of the electrolyte which is not routinely monitored and managed in sick patients. At the same time, besides phosphate, you have to be equally aware of sodium, potassium, magnesium, and even calcium in these patients. Now, a brief word about the trace elements and vitamin deficiency. Now, I'll not go into the details because this will be covered in like the nutrition in ICU patients. But what I would like to say is that there has been a lot of literature of the last many decades that should the ICU patients receive trace elements, vitamin deficiencies, what should be the dose? Do they really suffer from these element deficiencies or vitamin deficiencies? And if we supplement, how to supplement, what should be the dose and what should be the duration? Still we are evolving as far as the supplementation of trace elements and vitamins are concerned. So the key points for trace elements and vitamins are they have got important role. If you understand the physiology of these, we will understand they have got antioxidant role. They are like they have got some immune deficiencies. They have protect us against the infections, hospital acquired infections. And if there is some deficiency which is existing, then they can contribute to poor outcome. But The evidence is that sometimes what happens that even though the patients, you suspect that they would be having low levels of trace elements and vitamins, but it may be just because of the redistribution. So this is one of the dilemma in supplementing these trace elements and vitamins. So we are not sure like whether it is a redistribution or it is a true deficiency. But if you want to err on the higher, if you want to err on the good side as far as this replenishment is concerned, it is always better to think of giving vitamins and trace elements to all patients, especially if they have got risk factors of malnutrition. And if you want to err on the good side, you have to give the higher side. You can go up to at most like if what is the recommended dietary allowance, daily allowance, you can go up to 3 to 5 times of the normal allowances which are recommended by the guidelines. There are a lot of interventions and trials on selenium, vitamin C, vitamin D, but still, as of now, none of them have got proven benefits, and still we are evolving as far as these vitamins and trace elements are concerned. Just some trace elements and vitamins which have come over the last decade as far as the ICU patients are concerned. In sepsis, there has been vitamin C, mega dose of vitamin C going up to, some studies are there, like up to 16 grams in a day. Some say that you can go up to 8 grams, then thiamine, what dose. But still, if you say as of presence, the status is still controversial. Yes, those patients who are on renal replacement therapy, they should get vitamin B, vitamin C, copper, and zinc losses are there during the dialysis. They should be replenished. Again, we don't know what doses and what should be the duration. Vitamin D is a pleiotropic hormone, and we know that it almost influences all the physiological functions of all the organs. Yes, it should be supplemented, but if you look into the trials and the evidence, there is limited evidence that it has an outcome benefit. Selenium, zinc, they have antioxidant activity. They are like anti-inflammatory. They have good. They impair. They like those patients who have got poor immunity. They can enhance the immunity and prevent them from hospital-acquired infections. But again, we are not sure whether they really help in the overall outcome. There are some vitamins which need to be supplemented in those patients who have got some brain injury, but still we do not know what dose and how to supplement them and what should be the duration. But as far as the physiological functions of these vitamins and trace elements is concerned, they do have some role in the like maintenance of the membranes, the transmission of the all the enzymatic functions which are taking place in the body. And there are very rapid fluctuations and shifts of these vitamins and trace elements during critical illness, so they need to be supplemented, but still we are not sure what dose and what duration. Thank you very much for your patient listening.